welcome to The Explainer. Today, we are diving deep into a really persistent challenge in lipid management, what to do about elevated lipoprotein A. And thanks to a major 2024 clinical update, we finally have some real clarity on how to tackle this potent risk factor.
This is a scenario that I know we all face in the clinic. For years, finding elevated LPA has been, well, frustrating, right? It's this genetically determined risk factor, and our therapeutic options have felt pretty limited. But the path forward is becoming so much clearer, thanks to these brand new focused updates from the National Lipid Association and a consensus from the European Atherosclerosis Society. Okay, so let's get right into it. The single biggest development here is a fundamental shift in how we understand lipoprotein A. We're officially moving beyond just talking about correlation, we're talking causation.
Just look at this statement from the NLA. It is absolutely unequivocal. The debate is over. There's a solid consensus now across all the major scientific bodies. LPA isn't just a passive marker hanging around at the scene of the crime. It is a direct, independent cause of both ASCVD and calcific aortic valve stenosis.
And look, this conclusion isn't based on some small cohort. We are talking about massive population-based studies. Take the UK Biobank. That's data from over 400,000 individuals. This gives these findings some serious statistical muscle and really solidifies that causal link.
So if it's causal, what does that really mean for how we treat our patients? Well, it means we have to completely rethink how we stratify risk. The old way of doing things, it just doesn't cut it anymore.
We're basically retiring that simple black and white high versus not high model. The data is crystal clear. There's a continuous, log-linear relationship. So what does that mean in practice? It means the risk doesn't just suddenly switch on when a patient crosses 50 milligrams per deciliter. It's been steadily and progressively climbing the whole way up.
And that kind of thinking is exactly what's driving this huge push toward universal screening. Both the European Atherosclerosis Society and now the NLA are on the same page, saying we need to measure LPA at least once in every adult's lifetime. It's all about getting that complete, global picture of their cardiovascular risk.
And what the NLA did that is so helpful for us in the clinic is translate this continuous risk into these actionable tiers. They've defined low and high risk, but they've also critically added this intermediate gray zone between 30 and 49 milligrams per deciliter. This is basically a heads up that in certain situations, say postmenopause or in a patient with progressive kidney disease, you might want to check that level again.
So this is the bottom line, right? You've identified a patient in that high-risk category. What does our toolbox look like today according to the latest guideline?
First things first, the absolute foundation is to aggressively manage every other modifiable risk factor. And I mean aggressively. We're talking about getting LDL cholesterol, blood pressure, blood glucose right to goal. And yeah, while a healthy lifestyle isn't going to move the LPA number itself, it absolutely reduces the patient's total vascular risk, which is still a huge win.
Now, this is the million-dollar question we get from colleagues and patients all the time. If statins don't lower LPA, and hey, they might even bump it up a tiny bit, should we still be using them? Well, the guidelines are very, very clear on this.
The answer is an absolute unequivocal yes. Statins are still our first-line standard of care therapy, period. That's for lowering that powerful LDL-driven ASCVD risk. Any concern about that minimal increase in LPA should not be a reason to even think about stopping them. The cardiovascular benefits from the statin just blow that concern right out of the water.
Okay, so what about the residual risk in our high-risk patients who are already on maximally tolerated statins? Well, we have another really powerful tool we can use to go after the risk that's driven by that elevated LPA.
And that's PCSK9 inhibitors. On top of their potent LDL-lowering effects, they've been shown to lower LPA levels by about 20 to 30%.
This quote from the NLA really highlights the clinical sweet spot. They're basically saying that if you have a high-risk patient who needs more LDL lowering anyway, and they have high LPA, a PCSK9 inhibitor is a fantastic choice. It gives you a great 2-for-1 benefit, addressing that residual risk from both lipoproteins.
Now, let's talk about the most targeted therapy we currently have. This is lipoprotein apheresis, and it's the only therapy with an FDA-approved indication specifically for LPA reduction.
It really does stand alone. Now, It's an intensive therapy for sure, and it's not widely available. But for a very specific, very high-risk patient population, it remains an absolutely critical option to have in our back pocket.
And the criteria for apheresis are extremely precise. You really have to tick all the boxes here. Your patient needs to have both familial hypercholesterolemia and documented ASCVD. They have to already be on maximal lipid-lowering therapy. And, after all that, their LDL must still be over 100 and their LPA over 60. It's a very specific cascade, and all 4 of those conditions have to be met.
So while everything we've talked about so far is about mitigating a patient's total cardiovascular risk, the future is incredibly exciting. It's all about directly and potently targeting LPA itself. We're on the frontier of these RNA-based therapies. You've got antisense oligonucleotides, or ASOs, and small interfering RNAs, siRNAs. They work upstream, intercepting the mRNA from the LPA gene and basically halting the production of the ApoA protein right at the source.
And just take a look at this pipeline. It is seriously impressive. We have the ASO pelacarsen, which is reporting about an 80% reduction. And then you've got the siRNAs, olpasiran, zerasiran, reporting reductions of over 95%. I mean, that's almost completely wiping it out. And the best part? The major outcome trials, ELPA Horizon and Oceania, are fully enrolled, and we are all on the edge of our seats waiting for those results.
And, this brings us to the final, really provocative question. As we stand on the cusp of having these specific, incredibly potent therapies that directly target LPA, doesn't universal screening start to feel, inevitable? The argument for testing every adult at least once just becomes so compelling. The ability to move from simply managing global risk to directly treating this causal factor could truly revolutionize preventive cardiology.